Welcome to the first session in our 5-part Cancer Genetics Continuing Medical Education series titled Assessing Risk for Hereditary Cancer, the Importance of the Family History. Over the next hour, you will be hearing from patient advocate Janet Shimabukuro, as well as 4 genetic counselors, Tara Hansen, Katie Stoll, Rena Dhaliwal, and Julie Simon. By the end of the session, you should be able to describe common hereditary cancer syndromes and their features, recognize advancements in cancer gene identification, identify current guidelines for hereditary cancer risk assessment, recognize important indicators in the family history as related to hereditary cancer risk, and assess appropriate tools that may be used for hereditary cancer risk assessment. CME credit is available for watching this recording. If you are watching this in a group setting, please make sure you register for the webinar and complete the evaluation as an individual to receive CME credit. The accreditation statement is available on the Washington Medical Commission website. The Federation of State Medical Boards designates this as an enduring activity for a maximum of 1 AMA PRA Category 1 credit. Physicians should claim only the credit commensurate with the extent of their participation in this activity. A full statement of faculty and staff disclosures is available on the Washington Medical Commission website. This webinar is not funded by any commercial entity, and none of the speakers or planners for this activity have relevant financial relationships to disclose with ineligible companies. With that, I'll turn things over to our first speaker, Tara Hansen. Thank you.
Thank you. So this section of the talk will review just a few of the most common hereditary cancer syndromes. The idea is to present some of the most common conditions that we come across that illustrate some of the basic concepts that you can see across many of the different hereditary cancer syndromes. The first one to review has a somewhat historical name of hereditary breast and ovarian cancer syndrome, also known as HBOC or HBOC. This, however, is moving towards being called BRCA1 and BRCA2 cancer-related risk because we are now aware that mutations in these genes confer a risk for much more than breast and ovarian cancer. So a change in the name will help it to be more descriptive and accurate. Many people are familiar with this condition, both providers and patients, but some basic concepts to review would be that there are 2 genes that can cause this condition, known as BRCA1 and BRCA2. These commonly in the general public will be referred to as the breast cancer gene, but there are 2 separate genes certainly here. We may also hear them called BRCA or BRCA. Both of the genes are similar, even though they are separate, and they're similar in what they do and how they act. Both of them are autosomal dominant, so a mutation in one copy of either gene will confer the increased risks for cancer. And we've included here the different terms you may see on a genetic test report that would refer to a mutation. The nomenclature has changed some over time. So you may see anything from positive to mutation to pathogenic variant to deleterious to clinically significant. Both BRCA1 and BRCA2 have a similar role for the human body. They are involved with DNA repair, cell cycle checkpoint control, maintenance of genomic stability. So in general, a normal function for both of these genes will help to prevent cancer from developing. whereas a mutation in either one will disrupt that normal process and allow for the increased risk in cancer. We do have an estimated prevalence for both BRCA1 and BRCA2 mutations in the general population. This is around 1 out of 400 to 1 out of 500 people. But there is a select group, a population that has a higher incidence, and this would be those who have Ashkenazi Jewish descent, and the estimate is 1 out of 40 people carry a mutation in one of these genes. This table pulls out the cancer risks associated with both of the genes, BRCA1 and BRCA2, in comparison with the risk that is present for the general population. So the first note that you can see is under cancer site. Again, this is much more than female breast and ovarian cancer. We have expanded the list by doing research, and we now know that male breast cancer can be an increased risk, prostate cancer, pancreatic cancer, and melanoma. There are some differences between BRCA1 and BRCA2. It's not usually highly important to get into the exact specific risk numbers, except to point out that they are significantly elevated compared to normal. And that is what guides the management or change in care for these people. We do have standards for management for people who carry a BRCA1 or BRCA2 mutation. Of course, the goal is to identify these patients and these families to understand what their risk is so that we can ideally reduce their risk for cancer or perhaps prevent it from occurring, or at the very least be detecting cancers earlier so that they are easier to treat. Some examples of management, and there is much more detail available on written guidelines out there. But for female breast cancer, we can begin screening at age 30 with both mammograms and breast MRI, or even 25 for breast MRI. So it's much younger than the general population. Another example is with prostate cancer, we can start that screening at age 40. Again, much younger than the general population would have. We also have surgeries available to reduce risk, as an example. So removing the breast, removing the ovaries and fallopian tubes. These are ways to reduce risk for these patients. The next syndrome on the list to cover is Lynch syndrome. This also has a previous name, which was hereditary non-polyposis colorectal cancer, or HNPCC. Colon cancer was the first cancer identified for these families with this condition. Again, we now know that the list of cancer risks extends beyond the colon. Similarly to BRCA1 and 2, there's multiple genes that can cause this condition. Those 5 genes are listed on this slide. Again, they are separate genes. A mutation in any one of them will cause Lynch syndrome. They also are autosomal dominant. Their function is a little different than BRCA1 and 2. They're actually involved in DNA mismatch repair. So when errors or mistakes happen in our DNA, these genes step in to correct those. But again, ultimately, their normal function is helping to prevent cancer. We do, again, have estimated prevalence for Lynch syndrome in any of the 5 genes, and that number is 1 out of 279. And another way to think about this is that out of all the people diagnosed with colon cancer or endometrial cancer, approximately 3% of them actually have Lynch syndrome. Again, a table to show you the risks, the different cancers that can be involved. So we have colorectal, endometrial, ovarian, bladder, gastric, small bladder. The list goes on beyond this to include pancreatic, prostate, urinary tract, biliary tract, the brain, and the skin. to some extent. Again, the numbers vary somewhat between one gene to the next, but in general, the concept is that the risk is significantly higher than the general population. And again, that is what guides the change in management. The last condition to review would be the polyposis syndromes. These are broken down into two columns on this slide. On the left side, we have familial adenomatous polyposis, or FAP. On the right side, we have MUTYH-associated polyposis, or MAP. These are different in the gene that causes them, APC versus MUTYH, and how that gene acts. Their role is a little different. APC has a lot of different tumor suppression jobs that it takes care of. MUTYH is involved with damage repair. APC acts in an autosomal dominant fashion. So just like BRCA1 and 2 and Lynch syndrome, one mutation in the gene confers the cancer risk. Compared to MAP with the MUTYH gene, this acts in an autosomal recessive fashion. So a person actually needs a mutation in both copies of the gene in order to have the cancer risks. Both, thank you. Both conditions do involve many extra polyps compared to average. If you have classic FAP, it will be hundreds of thousands. If you have attenuated FAP, it will be fewer than that. If you have MAP, it will be fewer than that. The age of onset will be younger with classic FAP compared to the other two. Both conditions can involve other features as well, other cancers, for example, the thyroid or osteomas with FAP, the ovary or the bladder for MAP, other features even, the congenital hypertrophy of the retinal pigment can happen in FAP. So there's a number of other things that are part of these conditions beyond polyposis. And then we also have the prevalence included at the bottom here. For APC, it's 3 out of every 100,000 people. And for MAP, carrying one mutation in one copy of the gene is estimated as 1 to 2% of the general population, but these people do not have the increased risk. People with the full condition, the biallelic condition, the estimate is 1 out of 20,000 to 1 out of 60,000 people have that. Colon cancer management for both Lynch syndrome, the polyposis syndromes, other colon cancer conditions, again, certainly includes trying to prevent cancer if possible, or at least detecting it earlier. There are different guidelines, again, for the different genes that are involved, and those will vary depending on how high the risk is and which cancers are involved. Nearly all of them include starting colonoscopies younger and doing them more often as a major component of the plan. There, again, may be surgeries or other treatments that we could use to reduce risk over time. And I will pass it off to Katie now.
Thank you so much, Tara. So for my part of this presentation, I'll be talking about updates in cancer genetics, new genes that have been discovered since BRCA1 and 2 and the genes related to Lynch syndrome. And also conversations about direct-to-consumer testing. So over the last decade, there have been many new genes that have been discovered and have testing available for on a clinical basis. There's also been a growing business interest in genetic testing that's led to many labs now offering genetic testing and a growing number of labs in the direct-to-consumer space offering genetic testing. This can be complicated to navigate for both patients and providers. A little bit of history. So the BRCA1 gene was first discovered in 1990, mapped by Dr. Mary Claire King. In 1994, Myriad Genetics and the University of Utah were able to further localize that gene. And shortly thereafter, they were able to localize the BRCA2 gene. And at that time, they took a patent out on both of these genes. So for many years, there was one lab that was the only lab that was doing testing for the BRCA1 and BRCA2 genes. It was all the way back in 2005 when the United States Preventative Services Task Force began recommending that women at increased risk for cancer be referred for genetic counseling and consideration of BRCA testing. And a couple of years after that, another gene related to BRCA1 and BRCA2 called PALB2, standing for Partner and Localizer BRCA2, was discovered. Another important gene related to hereditary breast and ovarian cancer. In 2013, the US Supreme Court ruled that human genes cannot be patented in a case brought by the Association for Molecular Pathology versus Myriad Genetics. And that ended the monopoly that Myriad had on genetic testing and really escalated the commercial interest in genetic testing. By 2018, we saw that there were more than 300 tests on the market in the US that included analysis of the BRCA1 and BRCA2 genes. We know that there are many different genes involved in DNA damage repair and related to hereditary cancer risk. Oftentimes they're working together in the same pathways, and many times they're related to the same or some of the same types of cancers. Just to show now that when we are looking at hereditary breast cancer risk, for instance, we typically will use a panel of genes looking at multiple genes that have been associated with hereditary breast cancer risk. But again, these same genes that are connected to breast cancer risk are also associated with other types of cancer risks, and it really varies from gene to gene, as does the overall lifetime risk for breast cancer associated with these genes. Even from family to family, there can be quite a bit of variability with different specific genetic variants in different families. And we still don't have really excellent ways to kind of determine what causes that variability from family to family. So we typically will quote some range in terms of the overall risk associated with these genes. Additionally, there have been many genes that have been discovered that play a role in both hereditary colon cancer and colon polyposis syndromes, to name a few here. So it's now beyond the APC gene and the MUT-YH gene that Tara just reviewed, and the Lynch syndrome mismatch repair genes, but now oftentimes we're looking at multiple genes that play a role in different hereditary colorectal cancer or polyposis syndromes. So while initially testing was focused on one or two genes at a time, now it's common to see multi-gene panels that may include analysis of more than 70 genes at one time. There's no standard panel that's used by all labs, and the genes included on any panel may change over time. Guidelines for care are also expanding to include a growing number of genes, and these guidelines are being updated quite frequently over time, as well as new information is learned about these genes. Because of this, it's important to revisit genetic testing options over time. A patient who had genetic testing 10 years ago likely didn't have a test that included all of the genes that we would be considering standard of care at this time. I think it's also important to note that the test quality and coverage by labs is highly variable. There are many direct-to-consumer tests or patient-initiated, physician-mediated type tests that offer some version of genetic testing, including analysis of the BRCA1 and BRCA2 genes. The limitations of what these tests are looking at may not always be obvious to to the people that are using these tests. For instance, some popular direct-to-consumer testing may only look at a small number of specific genetic variants rather than a more comprehensive analysis of the entire gene or genes. And in that case, there's a risk for a false negative result or false reassurance, in which a family may have a genetic variant that wouldn't be detected by that version of a direct-to-consumer test. We've also seen that some of the direct-to-consumer tests will return a positive result when in fact clinical testing does not confirm that genetic variant in a family. So we always advise interpretation with caution of these types of tests, and that follow-up genetic counseling and testing in a clinical lab would be recommended before any clinical action was taken based on those results. A couple of case studies just to illustrate some of these points. I think this is just related to what we're often seeing now with the panel testing. Many of the clinically available tests that include many genes have a lot of overlap in the different genes that they're including. There can be panels that are designed to be very specific to genes connected to breast cancer or colorectal cancer, but there's so much overlap that oftentimes you'll see a panel that includes genes that cover multiple types of cancers. In this example, a patient undergoes a multi-gene panel due to concerns about her breast cancer risk, and is ultimately found to carry a pathogenic variant in the PMS2 gene, which you will recall is associated with Lynch syndrome, and not a defined increased risk for breast cancer, but a somewhat increased risk for colorectal cancer and endometrial cancers. This patient has no family history of any of those cancers, so it can be difficult to predict exactly what this means in terms of this patient's risk, and kind of taking that result into the context of the family history is important. And another case study. So in this family, a patient was diagnosed with breast cancer at age 42, was referred for genetic counseling, and at that time reported that her mother had had genetic testing and the results were negative. We asked to review these test results, and with the mother's permission, we're able to review the testing that was done, and it was recognized that the testing that had been completed was a direct-to-consumer test that was looking at only very select variants in the BRCA1 and BRCA2 genes. It was not a complete analysis. This young patient with breast cancer then undergoes genetic testing through a clinical lab and finds that she does test positive for a pathogenic variant, the BRCA1 gene, which is later also confirmed in the patient's mother. And unfortunately, these types of scenarios are coming up quite a bit now, and oftentimes it's especially challenging because oftentimes people are seeking these tests out because they know that there's a concern, and they're really hoping to get answers for these questions. So a couple of take-home points for this case. It's always important to verify what testing has been done in the family. Maybe don't just take it at report that testing's been done and assume that it's been complete. Recognize the limitations of direct-to-consumer testing. And I think also, recognizing families that have this risk and referring them on so that they can have a more comprehensive genetic counseling session and risk assessment and access to clinical testing if they're seeking answers about this type of risk. Another direct-to-consumer case study, which is another scenario that unfortunately we're seeing with some frequency, are people who have test results from DTC genetic testing companies that report positive for a pathogenic variant in the BRCA2 or other gene. In this case, there's no family history of cancer that would be suggestive of BRCA2 related cancer risk. And follow-up testing through a clinical laboratory did not confirm the variant that was reported. We know that oftentimes test results coming from these labs are not confirmed through follow-up clinical testing. So it's important to refer these patients on so they can have that confirmation or not through that next step. And as a last point, I'd just like to raise some awareness around genetic testing scams that are happening now. It's a huge area in Medicare fraud that we are seeing genetic testing targeted at Medicare beneficiaries through cold calls, through booth setup at county fairs, through just faxes that physicians get to their office asking for signatures, requesting genetic testing for their patients. So be aware also that while there is a lot of good that can come from the testing that's happening in this space, there's also some bad actors that are unfortunately preying on Medicare beneficiaries around genetic testing. So in summary, there have been many new discoveries of genes associated with hereditary cancer risk that have made personalizing care possible. Genetic testing has expanded, and now oftentimes we're using panels that look at multiple genes associated with many types of cancer. Sometimes this can be very informative and allow for preventative and risk-reducing strategies for patients. Sometimes it can be complicated in interpreting what these results mean for families in the context of their family and health histories. And also there's been a lot of expansion in the genetic testing industry in recent years, and there's not standardization in this space, and there's a lot of variability in the labs that are out there. And with that, I will pass it on to Rena.
Thanks, Katie. Hi, I'm Rena Dhaliwal. I'm going to be doing a review of NCCN guidelines and also reviewing a few cases, just kind of illustrating some examples. And specifically, we'll be focusing on personal and family history risk assessment for hereditary cancer susceptibility. So in general, we recommend genetic testing for patients with a personal or family history when there is a cancer diagnosed before the age of 50, 2 or more cancers diagnosed in the same person, 3 or more people on one side of the family with cancer, especially paying attention if these are the same cancer or cancers that we know to be related, like breast and ovarian cancer or colorectal and endometrial cancer, rare cancer types or certain pathologies, for example, like medullary thyroid cancers, pheochromocytomas, so more rare cancer types. Relatives who have tested positive for hereditary cancer syndrome, so when there's a known familial variant in the family, and then Ashkenazi Jewish ancestry for reasons that have been reviewed previously in this presentation. In general, we use NCCN guidelines as the primary reference text for family history risk assessment for hereditary cancer susceptibility. The breast, ovarian, prostate, and pancreatic cancer guidelines are summarized in this specific genetic familial NCCN guideline. For other cancers, sometimes they might be buried in the specific diagnosis and treatment, but for breast, ovarian, prostate, and pancreatic cancer, they are summarized in this reference text. And like others have mentioned, these are updated quite frequently, so it's important to make sure that you are referencing the most recent NCCN guidelines. So starting with breast cancer, genetic testing for breast cancer susceptibility genes is indicated when an individual has a personal history of breast cancer with these specific features. So if it's diagnosed at age 50 or younger, if it is triple negative disease, and again, this is not diagnosed at 50 or younger and triple negative, it's either 50 or younger or triple negative disease, so ER/PR HER2 negative. Someone has multiple breast cancer primaries regardless of the age, specifically lobular breast cancer versus like ductal. Male breast cancers, Ashkenazi Jewish ancestry, or if someone has a personal history of breast cancer, and then kind of red flags for things like family history of breast cancer below the age of 50, male breast cancers, relatives with ovarian cancer, pancreatic cancer, or high-risk prostate cancers. And then specifically for ovarian cancer, genetic testing is indicated in all cases of epithelial ovarian cancer. The majority of ovarian cancer is epithelial, most often serous adenocarcinomas of the ovary. And this can also include fallopian tube cancer or peritoneal cancer. So those, in addition to ovarian cancer, anybody, regardless of age at diagnosis, regardless of family history, any individual with ovarian cancer should be offered genetic testing. I know that in my practice, I'm seeing many people who were diagnosed with ovarian cancer decades ago that are now being referred for genetic testing, and that is an NCCN recommendation. So specifically now talking about unaffected individuals, so looking solely at family history, no longer looking at individuals who have a personal history of cancer. So anybody with a first or second degree relative meeting the breast and ovarian criteria. So this can be like an individual with a mother diagnosed with breast cancer at 50 years of age or younger, or a grandmother with ovarian cancer. Those are all individuals who would meet NCCN guidelines for genetic testing based on family history. So that those guidelines are pretty generous, and we do find that many people will meet NCCN guidelines with the first or second degree relative criteria. And obviously, if there is a family history of a known pathogenic germline variant, that individual would also meet criteria for genetic evaluation. Now, specifically moving on to prostate cancer, this is individuals who have a personal history of prostate cancer. So individuals with metastatic prostate cancer, high risk or very high risk groups. So for more information about the risk stratification groups, because it can get quite detailed, you can take a look at the NCCN guidelines for prostate cancer. Anybody with a personal history of prostate cancer plus a family history of breast cancer or prostate cancer in 3 or more blood relatives. So this can be first degree, second degree, or third degree, or personal history of prostate cancer and Ashkenazi Jewish ancestry. And now moving on to pancreatic cancer. So this is similar to ovarian in that anybody with exocrine pancreatic cancer should be offered genetic testing. So it doesn't apply to neuroendocrine pancreatic tumors. Those are talked about in a separate NCCN guideline, but anybody with an exocrine, so pancreatic and adenocarcinoma, should be offered genetic testing regardless of age, regardless of family history. And then specifically talking about the family history for prostate and pancreatic cancer. So again, these are unaffected individuals who do not have cancer. So anybody with a first degree relative meeting the criteria. So a parent or a sibling with with pancreatic cancer or metastatic high risk prostate cancer. Or a first degree relative of an individual with the pancreatic cancer, or somebody with a known pathogenic germline variant in a cancer susceptibility gene. Those individuals would all meet NCCN guidelines for evaluation. Moving now on to colorectal cancer. So the colorectal cancer guidelines and polyposis guidelines are summarized in the NCCN reference text that is pictured below. And this is the most recent version, but they again are updated frequently. So important to make sure you're looking at the most recent version. And so genetic testing for colorectal cancer genes is recommended when there's a personal history of colorectal cancer that is diagnosed before the age of 50, when there is a known MMR deficiency in the colorectal cancer tumor or endometrial cancer tumor. So all colorectal and endometrial cancer tumors undergo a screening for Lynch syndrome that looks at expression of MMR protein. So if there is a deficiency that is suspicious for a germline variant in a mismatch repair gene, then that is sufficient to prompt germline evaluation for colorectal cancer syndromes. An individual who has colorectal cancer plus another Lynch syndrome associated cancer, so whether that be endometrial cancer, ovarian cancer, bladder cancer, or someone who has a family history of a Lynch syndrome related cancer and a personal history of colorectal cancer. And in individuals who are unaffected, so who do not have cancer, testing is recommended when someone has a first-degree relative with colorectal cancer or endometrial cancer diagnosed before the age of 50, or if they have a family history of one or more first-degree relatives with colorectal cancer or endometrial cancer. Again, this is now regardless of age. And then again, for unaffected individuals, if someone has 2 or more first-degree or second-degree relatives with Lynch syndrome-related cancers, including at least one diagnosed before the age of 50, or 3 or more first-degree or second-degree relatives with a Lynch syndrome-related cancer, again, now regardless of age. So if there's 3 or more on one side of the family, age is not, we're not as concerned about age. And of course, if someone has a family history of a known pathogenic germline variant. Now going on to evaluation for polyposis genes. So for personal history, if someone has a history of 20 cumulative adenomas over their lifetime, or if someone has multifocal or bilateral TRPE, and we can also consider testing in cases where there are 10 to 20 cumulative adenomas. So even if someone doesn't have quite that cutoff of 20, but they've still had many adenomas and just over a few colonoscopies at a fairly young age, there are kind of provisions to consider testing in those individuals, and especially if they have other features of FAP like desmoid tumors or a young child diagnosed with hepatoblastoma. That's testing is indicated for FAP in those cases. So in now we're unaffected individuals, looking only at family history. If there's a known pathogenic variant in the APC gene or in the MUTYH gene, or if there's a family history of significant polyposis and that family member is either deceased or not willing to have testing, genetic testing can be indicated in those situations as well. So I wanted to review just a couple case examples. So this is a family where we eventually identified a BRCA2 pathogenic variant. However, the family wasn't necessarily a typical a BRCA family, and really the only cancer that we knew about was a pancreatic cancer in a grandparent. So just again, kind of stressing the importance of genetic evaluation in like non-breast and non-ovarian cancers, because sometimes, especially depending on the family structure, they may not present as your kind of typical hereditary breast and ovarian cancer family. This is kind of completely in contrast with the first case example, in that this is a BRCA1 family where it was highly penetrant when it came to the breast and ovarian cancer, and this is much more of kind of your textbook BRCA family that came to attention pretty quickly with that proband's mother once she had kind of the 2 breast cancer primaries and the pancreatic cancer. It was certainly very suspicious of a hereditary susceptibility, and we did end up identifying a BRCA variant in this family. And just my last case example here is reviewing a family with Lynch syndrome. Again, very textbook example of a Lynch syndrome family. 2 early onset colorectal cancers in the family, both of them with very obvious MMR deficiencies on tumor testing. Unfortunately, this proband's uncle did not want to get testing, so we weren't able to identify the Lynch syndrome until after the patient had already been diagnosed with colorectal cancer. So kind of an unfortunate case, but a very textbook sort of Lynch family. So that, I believe, concludes my case examples. I will pass things off to Julie for a portion of today's presentation.
Okay, thank you, Rena. And so I'm going to continue that fantastic presentation from Rena on other additional ways to assess the family history and these tools that we're going to use. So I'll be talking about different online examples and weaving in what it looks like and how we would use these in clinics, what it looks like on the provider side of things. We'll be talking about the benefits and limitations. So pros and cons as you're looking at these different models, and then additional clinic intake forms or paper forms that would put this information into use, and how to recognize referrals, which should hopefully be sounding familiar at the end of this talk. And so some general information about these risk assessment models is that the guidelines all advocate for similar goals. Mainly, the patient should have the option of accepting or declining the testing, and that they should have all of the information necessary to make informed decisions. So they should be able to think about or hear about the benefits and limitations, as well as the risks of testing, and choosing to not do the testing at this time. So these conversations should happen before any genetic testing takes place, as well as after the genetic testing takes place, regardless of what those results show. And not all of the risk models are complete or will pick up everybody who has an increased risk. So for example, some of the models will only ask about breast cancer, and that family may have multiple people with prostate or pancreatic cancers. Some models may, anticipate a certain size of a family. So someone who comes from a small family or doesn't talk to family members, that may not be as good for them. And some of the other things to consider as you're looking at these models or the patient in front of you is that ideally the best person to start with when we're talking about genetic testing is someone who's already had a relevant cancer diagnosed. So you'll see that reflected in some of these models, and that there are multidisciplinary teams out there who exist to help guide this testing, to help the patients and help you set up the screening recommendations and guidelines. And that they want to involve the patient and the family, since genetics is something that happens in the whole family, but is most relevant to the person in front of you. And so on the next slide, we're going to start with the U.S. Preventative Services Task Force, which does have a specific recommendation about genetic testing for BRCA-related cancers. And this is one that we think about a lot, since they do offer specific models and guidelines. So you can see here it has incredible detail going through who may benefit from genetic testing and genetic counseling. And if we can pull out this highlight here, what they found is that there are multiple clinical tools listed here that are useful when we're trying to assess who would most benefit from genetic testing and genetic counseling. No one tool could be recommended over another, since they each have their own benefits and limitations. But together, the sensitivity of these models is between 77 to 100%. So they do a nice job of picking up who would be appropriate for testing. And then to look at some of those tools that it specifically calls out, these models are used to look for that BRCA1 and 2 specifically. So like Rena and the others have talked about before, and it will highlight that it's important to get information from both sides of the family. For example, on this Ontario Family History Assessment tool, it's asking about breast, ovarian, and prostate cancer. However, you can see for prostate cancer, it's looking mainly at the age, where the younger age is more suspicious. But we know now that the metastatic prostate cancer, or those high grade and very high grade, are more informative when we're looking for these genetic links. And it may miss families who have relatives with the pancreatic cancer, as pointed out in those past examples. If we go to the next tool, again, you can see that it breaks down looking at family information. It recommends a referral with that score of 10 in either column or 15 together. That helps pick up some of these families where they may have different types of cancers that are present that don't clearly fit one or other of the BRCA1 or 2, even though we would test them together. For the next screening tool, this is the referral screening tool, and intended to look for who would benefit from genetic counseling. So again, you know, 1 or 2 checks. They try and make each one of these as easy as possible, something that you could quickly fill out. But with this one, it does not consider the prostate or pancreatic cancers that might be in a family and still have that patient meet criteria. The next tool will look at, again, pedigree assessments or family history specifically. They're looking for 8 or higher. So you can see things like male breast cancer or breast cancer in someone assigned male at birth automatically qualifies for this. A family with ovarian and breast cancer would automatically qualify, but does not look at prostate or pancreatic cancer as we would recommend in the newest guidelines. The 7-question family history screening. Just 1 or more positive, that gets your referral. So you can see the trends here as we're going through these screenings. There are some more detailed models. So on this next one that we're looking at, the Tyrer-Cuzick or IBIS, this one is a more comprehensive tool. It looks at the family tree on both sides, and helps determine not only the appropriateness of the BRCA1 or 2 genetic testing, but it also helps guide screening or assesses how likely or not likely someone is to develop breast cancer. And then they can use that for screening. So as it lists here, it does have its own limitations. It does tend to overestimate in someone with a known atypia, and it's only looking at BRCA1 and 2. It's not looking at any of those other newer genes that Katie had pointed out. And so on the next slide here, it's going to look at, or sorry, list out all of these different criteria that we're looking at. It gives you this nice format that tells you that person's risk compared to average. And then on the next screen, you can see the example that includes those details that you would have filled out. It looks at the 5-year risk and the lifetime risk of developing breast cancer. And in the middle there includes the probability of testing positive for a BRCA1 and 2. So it is a nice comprehensive model. Now with patients who have already had genetic testing, when they come in to meet us, we'll look at some of these other risk models that exclusively look at how likely it is for someone to develop breast cancer, even if they've had negative genetic testing. And so one of those is the Gale model. And so you can see some information here. Again, it looks mainly at that 5-year and lifetime risk of breast cancer. And it's used to see who would qualify for additional breast screening, even with negative genetic testing, and who may benefit from chemoprevention therapy. And so on the next slide, again, it runs down what information it's going to ask you for when you're using this model, the nice table with colored graphs that it prints out for you, and some of the specifics or limitations that we would review with the patients when we're going through these models. Okay, and then how to use all of this information. Like I said, this should be sounding very familiar by now, but generally anyone diagnosed at, younger than 50 would meet criteria or should have a referral. 2 or more cancers, 2 primaries in the same person, 3 or more on the same side of the family in either side, rare types or certain pathologies that have already been outlined. Someone who's tested positive in the family would be enough for a referral. Certain ethnic backgrounds would meet that criteria. And there are forms that have been developed that can be used online or in person on paper on an iPad in the clinic that the patients themselves can click through or write out while they're waiting to be seen. So they can go through these forms themselves, hand that to you, and then you can run that assessment and see who would meet criteria for a referral or for testing. And then to summarize all of this information, there are some insurance companies that add their own criteria on top of these risk models. And there are no one model that is perfect for everybody or widely applicable. They all have their own limitations. They do recommend having a conversation with someone who's familiar with these nuances, who can go through that information with the patients as they're trying to make their decisions. And genetic counseling or someone familiar with this genetics would be helpful, even if the patients had normal testing or opted not to do genetic testing at this time. And then we'll use that information to put into place their own screening and surveillance plan or do the genetic testing if it has not been done yet. or evaluate past results and see if updated testing would be applicable for them. And so with that, we also included some additional references if you wanted to go back and look through those. And I will hand it off to Janet to tell you her story as she was going through this process.
Thank you, Julie. Appreciate that. So my story today starts with a little bit of history. So it was my grandfather and his 4 brothers immigrated from Switzerland to the United States in the 1920s with the American dream. Once they knew they could make it work here, my grandfather and his brother, that you see in the picture here, they returned to Switzerland in hopes of finding wives. They wanted life partners that shared their language and cultural traditions, and they fell in love with 2 sisters. So in 1936, brothers Joseph and Gottfried Schilter married Anna and Catherine Heinzer in a double wedding ceremony in Lauert, Switzerland. That same year, the 2 couples moved to Washington State to start their families. So we're going to fast forward to February of 2000, and my father, seen here on the slide, who was the second eldest child of Joseph and Anna, was having surgery for prostate cancer. The day after his surgery, a blood clot traveled to his brain and he suffered a massive stroke. He was permanently disabled for the next 10 years. And during that time, his cancer was spreading throughout his body and was in his bones when he passed in 2010 at age 72. The following year, Fred, son of Gottfried and Catherine, and double first cousin to my father, passed away after battling prostate and pancreatic cancer. Later that same year, his daughter, who is my second cousin, was diagnosed with stage 3 breast cancer. And in January of 2012, she had genetic testing and learned that she carried the BRCA2 mutation. But because her mother had also battled cancer, she falsely assumed that her genetic mutation came from her mom. So although her dad was no longer living and couldn't be tested, this was a missed opportunity to test her mom to confirm which parent carried the mutation that she inherited. On October 16th of 2019, my husband felt a lump in my breast while we were cuddling in bed. I was 46 years old, did my annual mammograms, but this was 2 months before my regularly scheduled test. It was a hard lump about the size of a marble. First came the ultrasound, then the needle-guided biopsy to learn that I had stage 1 invasive ductal carcinoma. My breast cancer was triple positive, which guaranteed chemotherapy. So I started treatment in November of that year and met with the Genetic Support Foundation for genetic counseling because I was younger than 50. So when I met with genetic counselor Katie Stoll, I was convinced that I didn't have the BRCA mutation because there wasn't really a history of early onset breast cancer among my close relatives. However, there was aggressive prostate cancer with my dad and my uncle, who not only battled prostate cancer, but he also battled melanoma and stomach cancer. So it was during my first meeting with Katie that I learned that the BRCA mutation often presents as prostate cancer in men. Who the heck knew that? I felt frustrated that I was never asked about my dad's side of the family when I went for my regular mammograms. I recall the day that Katie called me to share that I'd tested positive for the BRCA2 mutation that my second cousin carried. For the first time, I knew that the mutation came from our fathers because that's our only blood connection. I have a strong faith, and it was between the tears that I shared with Katie that I realized that I was the missing link, that this was the reason God chose me to have cancer, so I could share this important information with my family. So for me, this information sealed the deal for my surgery decision. And on that day, I realized that I would not be having just a simple lumpectomy. I knew that a bilateral mastectomy and a preventative hysterectomy were necessary to protect my health. So I was quick to share the news with my siblings, as well as other relatives that should be tested. And we went to the oldest living relatives because we realized that that would be most efficient to have those people tested first. I have 3 siblings, and 2 have tested positive. This is a picture of me and my sister Eileen. when she shared with her doctor that I tested positive for this mutation, her doctor, she tested positive. She's one for the mutation. And so her doctor said, I want to order a baseline MRI, even though you just had a clean mammogram. And it was in that MRI that they discovered her stage 1 breast cancer as well. Her doctor explained that her cancer likely would have grown undetected for years and may not have been caught in her regular mammograms. So she opted for a bilateral mastectomy and also a BSO surgery to minimize her risk. Because our mastectomy surgeries were during the pandemic, we couldn't have family with us in the hospital. So we joked that our husbands had to just drop us off at the curb. I don't think it was coincidence that our surgeries were scheduled the exact same day, just 1 hour apart. So we were able to recover together in the same hospital room, and we were known as the sisters. So I had 6 rounds of TCHP chemo, the stuff that made me really sick and lose my hair, followed by bilateral mastectomy, reconstruction, and hysterectomy. So I sometimes wonder if I would have chosen to have a preventative bilateral mastectomy if I had known about my risk before my cancer and was actually given a choice. It could have prevented the horrible chemo regimen that I endured. After my diagnosis, I started asking lots of questions about my family health history. And I learned that my grandfather had a mass removed under his nipple around 1950, but that was before it would have been recognized as breast cancer. So a cousin in Switzerland, who is only related on my grandfather's side of the family, tested positive for our mutation. So we can now say with certainty that it came from our grandfathers and not our grandmothers. It was a bit of a mystery before that. We couldn't say for certain, but we can now. So my sister and I both feel strongly that this information was truly a gift for us and has helped extend our lives. We were born with our genetic makeup. And getting tested hasn't changed anything, but it has given us important information that we can use to protect our health. I explained to others that our BRCA mutation was really hidden in the generation before us because it was in the men. So no one was making the connection between prostate cancer and breast cancer. And it often presents as breast cancer in women much younger, which it has in my family. My cousin and I were both diagnosed at 46 years of age, but her niece developed breast cancer at the young age of 28. Our children who have tested positive for our mutation can take steps to protect their health. And I really feel strongly that all of us who know and understand that these high-risk mutations can pass from a mother or a father must share this information to help others make that same connection so everyone can be educated and know their risk, because we know early detection saves lives. So I want to leave you with an analogy that I've used over the past several years to help people understand that preventative surgeries are not an extreme measure for a woman with high risk. If someone told you that the airplane that you were about to board had up to an 84% chance of crashing, would you get on it? If they explained that there was another route that would be long and tough, but get you to the same destination safely, would you take it? So that is the analogy I use to describe the path of preventative surgeries for women with a known high-risk mutation. Information's power, and we all deserve to know our risk so we can make informed decisions. Thanks for the opportunity to share my story. May you be blessed with good health and happiness. So with that, I'll turn it back over to Katie.
I'd like to thank all of our speakers today for volunteering their time to contribute to this continuing medical education opportunity. And I'd like to thank all of you for taking time to view this session, Assessing Risk for Hereditary Cancer, the Importance of the Family History. Speaker bios, as well as links for the other sessions in this 5-part series, can be found on the Washington Medical Commission website. On this website, you will also find a link to the webinar evaluation. Completion of this evaluation is required in order to receive CME credit. Thank you again for your participation in this webinar.